Okay, Assalamualaikum, good evening everyone. Okay, so truncal block for kids. It is not as glamorous as the limb block or the plexus block or the motor sparing block. But for me, truncal block is very versatile. Okay, and it is good for the new MO, those who want to learn in terms of the scanning, needling, controlling both of your hand to practice with truncal block. Because most of the time, if in pediatric, the patient is asleep. If in adults, some of us also practice when the patient is under GA. Okay. So this is my hospital, Hospital Sultanah Bahiyah, covered with the green and covered with paddy field. But if you go now, it will be yellow because of the harvest season. Our OT is at the left wing. We have where we work. And this is our regional center, regional corner. But most of the time, I perform under GA. So this is how I work. That one is to keep me warm. Okay. I have nothing to disclose except my patient and towards the regional and pediatric anesthesia. Okay, so as you know, truncal block for pediatric or even is for adult, as long as within from anterior, posterior and lateral, you can do it in adult, you also can do it in pediatric patient. And the highlighted one are those that I've commonly performed for my patient. Before we go further, one that I want to highlight is that in terms of the physiology, the myelination of the peripheral nerve in pediatric only complete by the age of 12. So, if you have to give a diluted LA, as long as it is more than the MLAC, minimal LA concentration, the LA can still provide a complete block. As most of the time, the block is for analgesia, not anesthesia. Okay? And when we talk about the truncal block or interfacial block, you have to understand the layering. So for pediatric patient, it is very thin and it's very superficial and each of the layer is very close to each other. Okay? So this is just to show the scanning of the anterior abdominal wall. Okay? The rectus muscle, the beginning of the 3 layer of the anterior abdominal muscle, and as we go lateral, then you can see the end of the transversus abdominis and the beginning of the quadratus lumborum. And the depth is only about 1 centimeter. This is a scan on the pediatric patient about 2 years old. Okay, but if you're doing in neonate, it's be about 0.5 centimeter. So it helped to know the depth so that we can decide on the length of the needle. Most of the time, the rectus sheath and the ilioinguinal nerve, I only use 25 millimeter. And for the other truncal block, I use a 50 millimeter needle. And this is my main reference for LA selection, as well as dose and dilution. Most of the time, we advocate or we advise the medical officer, the maximum LA for pediatric patient is 2 milligram per kilo. But there's a big but here. When it comes to interfacial block or plexus block, because of the high vascularized area and rapid, bigger surface area for absorption, which provide rapid absorption, there's an increased risk of LA toxicity. So the maximum LA is reduced to 1.5 milligram per kilo. And when you're doing truncal block, you usually give bilateral. You have to divide into 0.5, 0.75 and 0.75 milligram per kilo per side. So, in adult, you talk about 20 to 30 mils for the truncal block to open up the space to let it spread. But in pediatric, we talk about 0.2 mils per kilo. If the patient is 5 kilo, 0.2 mils per kilo is about 1 cc. Can it open up the space? It can. Okay. So, we start with iliohypogastric ilioinguinal nerve. This is the bread and butter of the truncal block or the block for pediatric patient. It can come to you for your cases, or it can come to you for the exam question. Okay? So, usually we offer for patient coming in for inguinal hernia repair, varicocele, hydrocele, or unilateral undescended testis, because the surgical incision is the same. Okay, except that when they want to cut the scrotum for the undescended testis, you have to give LA infiltration at the scrotum, and because this is truncal block, we have to anticipate when would be the pain. I don't usually give fentanyl for most of my hernia or undescended testis at induction. When we anticipate the pain when they manipulate the inguinal sac, when they manipulate the testis, as well as when they're tunneling, then give the fentanyl rescue. Okay, anticipate and give. Alright? So, point A, B, and C. Where do we usually do ilioinguinal block? Or you don't do it anymore? Landmark technique. Okay, we have been teaching I have been taught and I've been teaching others, the junior, to do it at point C. It's medial and inferior to the ASIS. Okay, in terms of the anatomy, the adult and pediatric is the same. It's just that the bigger the children are, the distance from the ASIS get further away. But it shouldn't be more than should not be more than 2 centimeters from ASIS. Alright? How do we do it? Usually the needle inserted at point C, perpendicular. Okay? As we advance, appreciate the pop. The first and the second pop, aspirate. Make sure you aspirate because there's an artery there. Aspirate, no blood. Deposit half of the LA and then pull out, go down, first pop, deposit the rest of the LA. Okay, that's simple. That's textbook. That's how you should answer. If you're going for exam, you get answer for this. Okay? But point A, point B, and point C. This is very important here because if you look at Nasara website, they say it's point A. Is it wrong? No. How can it be wrong? Okay, point A, point B, and point C, I've tried all in 3 points. It worked really well as a landmark technique. Because you need to understand the ilioinguinal and iliohypogastric nerve, as they travel posteriorly, they were within the, in between the internal oblique and transversus abdominis muscle. But at the laterally, at the ASIS, the iliohypogastric nerve, it pierces the internal oblique and superficializes and lay down between the external and internal oblique. That is why, at point A, this is how both of the nerves lay down together. Alright? But at point C, the hypogastric nerve is 1 layer above. That is why, for landmark technique, at point C, we ask you to feel to pop and then give 2-point injection. Okay? Alright. But what if you want to do ultrasound? Usually ultrasound is done at the point A. 1/3 lateral of between the umbilical and ASIS. This is where the probe is put. This is how you're going to see it. Both of the nerve is at the transversus abdominis plane. So you feel 2 pop, you don't have to give 2 times, you just 1 time, the whole LA is enough. Okay. So this is ultrasound-guided ilioinguinal nerve. Usually I use a linear probe. I don't really need to use a narrow footprint. Okay, position 1/3 lateral. Okay, appreciate the ASIS. And look for the this is where, okay? Alright. So the LA amount, if you do ultrasound guided, can be cut down to 0.1 ml per kilo. So for this patient, I only give about 1 cc and it really worked. The most important thing is, when you do ilioinguinal nerve block, do not compress. After you perform the block, do not compress because even though usually we compress to help to spread, but if you compress it, it will spread downward and block the femoral nerve. Then your patient cannot be discharged and then parent will be anxious, right? And then please, also the surgeon sometimes after we give the block, then they go and palpate, feel where's the testis, or they try to reach the hernia, and then your block also spread out. Okay. So we go to quadratus lumborum block. Okay. This is quite a good block that is very really help me in my practice. Okay, so in pediatric, I do it in supine position. I use linear probe, okay, but I put the roll underneath the patient so that it elevate the abdomen, and this position give me a better access when I want to scan and look for the lateral, posterolateral area, and of course, just push the hand away lah. Yeah, okay. So you can see the 3 layer. Okay. So this is 8 month, 6 kilo. 6 kilo, 0.2 mils per kilo will be around 1.2 mil of LA to be given. 1.2 mils of LA to be given. Usually my target will be this thick myofascial complex. Okay. It is 3 or 4 layers, may not be easy. You can pierce them, sometimes we cannot hydrodissect them. So I will come quite lateral. I didn't go through the transverse abdominal plane and open up because I only use 50 mm needle. So I want to be able to go as posterior as possible, even if I could go reach the lateral quadratus lumborum block. Okay, it is not easy, and somewhat in pediatric because it's very thin. You want to see the shaft and the tip. Okay, if I don't see the tip, I'm not going to give it because my LA, that 1.2 mils is very precious. Okay, go as far as possible, and when you get a good plane, give it. Okay. Okay, when you see the needle, the tip, and then start injecting. If not, stop. Okay, and when you do pediatric block, the dead space within the needle, the dead space of the catheter is also very precious. That is about 1 mil. So I really have to count on that. Okay. All right. Prof said a pretty picture provide a pretty block, but sometimes in pediatric patient you cannot get the pretty picture, but you still get a pretty block because I think in pediatric patient God love them. So it help you even though the volume is small, you give that. Because I think the fascia is not watertight, it can easily absorb, and then after that, you put the patient supine, the surgeon compress them, it helps in terms of the spread. So this is the patient, they still wake up very calm, pain-free. Okay? It depends whether where, usually this is where I targeted it, and whether I can pierce or I don't pierce, I can try to deposit somewhere here. Okay? Another patient, most of the time, you get a virgin abdomen, but not every time. So this patient, ileostomy and transverse colostomy, you cannot do from umbilical, slide laterally because of all the tegaderm or the stoma. So I have to start immediately laterally around the petit triangle area. Okay, so try to get into, this is always my target because I want to go as close as possible. Okay. If you can see here, there you can see the several layers of the fascia. And try to pierce each of the layer, but sometimes it is not, it won't be perfect, but apparently it really works for most of my patients. Most of tumor patients, usually we give about only 0.05 milligram of morphine just to counter when they manipulate the bowel and full up. But if it is just an adhesion or stoma revision, I don't really need morphine, just fentanyl at the end so that the patient wake up better and give some paracetamol or ketamine. Okay. So this is for those who are occasional pediatric anesthetists, the patient come to you occasionally. This is a quick reference of the pediatric anesthesia book. You can get it from our website, the Malaysian Society of Paediatric Anesthesia. And in there, there's a quick reference of block and dose for pediatric regional anesthesia. I thank the committee for inviting me, and thank you for regional family because always keeping me around. Thank you very much.